Hi, I'm Lauren Henke, and today on the NRG Oncology podcast, we bring you an episode devoted to our young patients facing a diagnosis of breast cancer. For years, we've seen a trend in the United States of increasing breast cancer diagnoses in patients who are under the age of 50. For this reason, we've brought together a number of guests to speak about the scope of this problem and what NRG Oncology is doing for these patients with early onset breast cancers. Our first guest on the podcast is Dr. Shannon Puhalla, who is a breast cancer medical oncologist at the University of Pittsburgh Hillman Cancer Center. She's also the protocol officer of NRG-Oncology BR009, looking at breast cancers in young premenopausal patients.
Dr. Puhalla, welcome to the NRG Oncology podcast. First off, could you speak about the scope of the problem of increasing breast cancer in our younger patients? Do you have any insight why we are seeing this trend?
Thank you, and thanks for inviting me to speak today. This is definitely a public health problem. We are definitely seeing an increase in breast cancer in young women, which is interesting because overall we're seeing decreases in breast cancer in older women. But we think that in part, one of the most important factors that is increasing breast cancer in young women is hormone exposure. What we mean by that is that in general, women are getting their menstrual cycle or their periods are starting earlier than they historically had. On average, that's about 6 months earlier than in previous generations or previous time points. And we specifically are seeing early puberty more in African American women, Hispanic women, and women who have a lower income household. So we think it's probably in part related to activities such as childhood obesity, also probably some degree of environmental exposures that we think can disrupt hormones. Not only are women getting their periods sooner, they're going into menopause later. Families are smaller and women are having children later in life. That also increases that exposure to the regular hormones that are in someone's body. The other part of that is lifestyle, which ties into the hormones, but the lifestyle that we think about as being important is diet. Seeing an increase in obesity is leading to an increase in breast cancer, particularly hormone-driven breast cancers. Many of us are spending our days behind desks and not getting the level of exercise that we had in previous generations, so that's probably contributing as well. And initially, we had thought that alcohol was more important in older women, but also seeing an increase in alcohol intake in younger women, which probably causes some hormone disruption, DNA damage, and then we're also seeing higher levels of binge drinking, particularly in younger women. It's really easy to go down a rabbit hole thinking about the day-to-day exposures, but probably things like air pollution, things like plastics, pesticides, some of those other exposures that we're getting can lead to endocrine disruption.
That's such a helpful overview and just really informative of the scope of the problem that we're facing. Before we delve into the overall scheme of the trial at hand, NRG Oncology BR009, I do know there are a lot of terms and abbreviations involved with this trial that can be confusing to patients and even to healthcare providers. Could you just spend a little bit of time here at the jump defining some of the key terms involved with the trial? Things like AI, ER, oncotype, ovarian suppression, and offset. And are there perhaps other terms too that might need to be clarified to a layperson or a patient considering this trial who might be listening?
We know that breast cancer is different whether we see it in younger women or older women. And the way that we think about dividing breast cancer is pre versus postmenopausal. So premenopausal women who are still having periods, postmenopausal women who are not having periods or have gone through menopause. Now, the other important thing to understand with the differences in breast cancer is that there are some breast cancers that are hormone driven and there are other breast cancers that aren't. We have our hormone-driven cancers, and sometimes you'll see those called HR positive, so hormone receptor positive. Other times you'll see ER or PR. So ER is estrogen receptor, PR is progesterone receptor. That's actually our largest group of breast cancers, and that's the group of breast cancers that we're focused on in this trial. There's other types of breast cancer. There's the triple negative, there's HER2 positive. That is not what we're looking at in this specific trial. The other kind of acronyms that we think about AI, so AI stands for aromatase inhibitor, not AI, artificial intelligence, which we think a lot about in medicine right now. But the aromatase inhibitors are one of our types of hormone blocking medicine. When we think about this large group of hormone receptor positive cancers, the main way that we treat those is by blocking estrogen or blocking hormone signaling. And in theory, just to kind of understand it, if you're blocking estrogen, you're inadvertently blocking progesterone as well, because progesterone signaling happens through estrogen signaling. The two main therapies that we have for hormone-driven breast cancers are tamoxifen, which is an older drug that we've historically used for a long time, and then the aromatase inhibitors, or the AIs. Tamoxifen turns on the estrogen receptor in some tissues and turns off the estrogen receptor in other tissues. In the breast, tamoxifen turns off the estrogen receptor and estrogen receptor signaling. Now, the aromatase inhibitors work because when women have gone through menopause, typically on their own just naturally, your ovaries aren't making estrogen anymore. But when your ovaries don't produce estrogen, your body essentially takes other hormones and turns those other hormones into estrogen with this enzyme called aromatase. So when we're using the aromatase inhibitors, it's blocking that enzyme that makes estrogen. So you're getting rid of the estrogen so that in turn it doesn't stimulate the estrogen receptor, whereas tamoxifen is working at the estrogen receptor. Sometimes in younger women, we will actually choose to put them into menopause as part of their cancer treatment. And that's really the key to where the 009 study or OFSET is looking at. We have some data that in younger women who have higher risk cancers, so lymph nodes involved or higher risk defined as needing chemotherapy, that when we compared putting someone into menopause or what we called ovarian suppression and giving those women an aromatase inhibitor compared to tamoxifen, the strategy of the ovarian suppression or putting women into menopause was more effective than tamoxifen. Offset is specifically looking at this. So when we're putting women into menopause with chemotherapy, is that really where the benefit of chemo is? We think of chemo working by killing cancer cells that are rapidly dividing, but some of the benefit of chemotherapy is that chemotherapy is putting women into menopause. So that's really the crux here of the study, is that if we put women into menopause with medication, not with chemotherapy, is chemotherapy still helping?
With that all out of the way, could you tell us about the scope of the problem that BR009 or the OFSET trial is seeking to solve? The trial is called Testing the Addition of Chemotherapy, as you've just talked about, to the usual treatment of ovarian function suppression plus hormonal therapy in premenopausal, estrogen receptor positive, HER2 negative breast cancer patients who are at high risk of their cancer returning. How exactly are we defining this high risk?
When we think about how we determine who gets chemotherapy or not, historically, if you have 4 lymph nodes involved or more, our bias is to give chemotherapy outright. And in lymph node negative women, or in women who have 1 to 3 positive lymph nodes, that's the group that we're not always sure if chemotherapy should be given. There was a couple large studies that had been done previously looking at, can you identify which women who have hormone receptor positive breast cancers and 0 to 3 positive lymph nodes actually need chemotherapy? And that's where the Oncotype was developed. The Oncotype was actually developed years ago on some of our older NSABP or NRG studies that had been done back in the 80s and 90s looking at the benefit of chemo. And the important thing to know is that in these hormone receptor positive cancers, the main treatment that's giving benefit is treatment that blocks estrogen. And does chemotherapy add to that? So what was determined is that this Oncotype assay could discern which estrogen positive cancers benefited from chemotherapy when added to the hormone therapy, or which cancers did not benefit from chemotherapy. And the way that it shakes out is that about 2/3 of cancers that are hormone receptor positive actually don't need chemotherapy at all. Chemotherapy adds nothing to reduce the risk of cancer recurrence. The group that we're looking at is women who have some high risk features, but maybe don't have a high risk oncotype. So what do you do there? What do you do if you have someone who's young? And we know breast cancer tends to be higher risk in younger women compared to older women. What do you do if someone has positive lymph nodes, so historically would get chemotherapy, but then their oncotype score isn't high? It's people who have some high risk features, but then have an oncotype that tells us that maybe chemotherapy isn't helping. What was determined in this group of patients looking at some of our previous studies is that if chemotherapy put women into menopause, then they got benefit from chemo. But if chemotherapy did not put women into menopause, they did not appear to get the same advantage. That really is what drove us to the question of, is it that chemotherapy is killing cancer cells, which is what we think it's probably doing in women with high oncotype scores, or is it that chemotherapy is putting women into menopause because it damages the ovaries, and then it's that better hormone treatment, so it's the putting women into menopause that's helping their cancer or reducing their cancer recurrence, not the actual cancer killing part of chemotherapy. That is the crux to this study, is to say, is the benefit that we're seeing because the chemotherapy is putting women into menopause compared to whether it's killing cancer cells. The only way to test this is that we have to put everyone into menopause and we have to give them an aromatase inhibitor, which is our best hormone therapy, and then see, does chemotherapy still help? So the randomization is that if we give everyone the best hormone therapy, which is putting them into menopause and giving them an aromatase inhibitor, if we give chemotherapy, do people still do better? So that's really what we're looking at, is does chemotherapy add benefit beyond just putting women into menopause?
That's such a good way of framing the essential question at hand in this trial, and I think is really digestible. But I'm curious, when you present this trial to patients, how do you like to break it down for them? And are there common questions that people have about the study and whether or not it makes sense for a patient that they're taking care of or for a patient in front of you?
I do find it to be difficult to explain because there's a lot of things at hand, and it's very overwhelming to go through a breast cancer diagnosis. And often, when patients are meeting the medical oncologist for the first time, we're throwing a lot of things at patients. We're throwing the oncotype, why we're doing the oncotype, we're throwing chemotherapy, we're throwing the endocrine therapy, the different types, and then all these different acronyms again makes it really challenging. If I'm seeing somebody and I'm talking to them about the study, so someone who's premenopausal, 0 to 3 lymph nodes, potentially eligible. So the way that I'll explain it is that because your cancer is hormone receptor positive, the main treatment benefit that we give is treatment that blocks estrogen. So we can do that in one of two ways. We can either give tamoxifen, or we can put you into menopause and give an aromatase inhibitor. And data that we have suggests that if we put women into menopause and give them an aromatase inhibitor, that there's less chance of the cancer coming back. Now, some women also need chemo. And the way that we determine if chemotherapy is needed is to send off an assay on the tumor like oncotype. So oncotype is an assay that's run from the tumor that was surgically removed. The pathologist will cut off a little piece of that tumor, and the tumor goes to the lab, and the lab looks at the genes in that cancer. The gene expression in the cancer will divide it into either a high-risk cancer or a low-risk cancer. If the cancer comes back high risk on the oncotype, then chemotherapy is needed on top of the hormone therapy. If the oncotype comes back low risk, then chemotherapy may be helpful or it may not be helpful. Our standard for a woman who's premenopausal and young is to get chemotherapy, because there's studies that have shown that there's a small benefit, about a 5% absolute benefit, to getting chemotherapy if you are premenopausal and have 1 to 3 lymph nodes involved. But data that we have historically suggests that that benefit to chemotherapy may be linked to whether or not chemotherapy is putting women into menopause. So there's another school of thought that if your oncotype score comes back low, but you still have lymph nodes involved, then that's the situation where we may opt to do ovarian suppression, so put someone into menopause and give them an aromatase inhibitor. So right now, we don't have a clear answer in this group of patients. The study is looking at that specifically to help us to know in a large prospective way that the chemotherapy, whether it's adding true benefit or not, when women are put into menopause in a different way. We think that both of these strategies are valid. We just need to prove that. The big challenge is sometimes people feel pretty strongly about which way they want to go, even though we don't technically know which way is best.
So, for investigators out there who, as you describe, are in the middle and aren't dug in on one side or the other, and who might be looking to open this trial at their center, there's that Michael Jackson song, You Are Not Alone. What sort of resources are there for BR009 to either get it open or to work through any logistical challenges? And what sort of barriers has the team so far seen to accrual, and what kind of solutions do we have in the pipeline?
We have a number of resources. This is a clinical trial that is open up through the NCI mechanism. So any site that opens up NCI sponsored studies, CTRN studies, these are our large federally funded trials. Sites that open those, which there's hundreds, probably thousands of sites in the country, can join the clinical trial through their typical mechanism. Once you're able to open it and it goes through the central IRB, so quick process, but once it is open, we have developed a number of educational materials to help. And realizing that it's a difficult study to explain conceptually, we have videos that we've developed, which conversations very similar to what we're having now, where we've got a couple different investigators who go through how they explain the study to patients. So how do you explain it to patients? What are some of the common questions you get? We also do webinars where we go through the background, the rationale, the eligibility for the clinical trial site aimed towards the study staff, the study nurses, and the other research teams to help them understand the nuance of the study and how to better explain it. Myself or any of the other investigators that are involved in the study, Dr. Swain, I know you'll talk to later, we are happy to talk to anyone as well to help to explain it. The barriers are that it is a sensitive patient population, and certainly going through cancer is difficult for people of all ages. It's not that it's not difficult for older women, but younger women face unique challenges. Women who are just building their careers, who have young children, who are balancing maybe taking care of older parents. Now they have their own health problem. Women who are trying to work and get their cancer treatment, dealing with side effects of premature menopause, hot flashes, night sweats, sleep disruptants. All of these things can be certainly more challenging when you've got a lot of other things on your plate. In terms of the other barriers, because it's so polarizing, chemotherapy or not, and the idea of being aggressive or not aggressive, sometimes there's this misunderstanding that you've got to do more in order to be aggressive, or the more you do, the less chance your cancer has to come back. But it's really more thinking about biologically what's the right treatment for someone. Because we can give chemotherapy, but if it's not helping, why would we do that? Why would we put people at risk of permanent neuropathy, heart damage, all of those other potential risks that we see with chemotherapy if it's not really helping? And that's really what we're aiming to do here, is to give people the right treatment for their cancer so that we're minimizing risks without getting actual benefits.
Dr. Puhalla, thank you so very much for this really excellent overview and for also, of course, coming on the NRG Oncology podcast to speak about early onset breast cancer and, of course, NRG Oncology BR009 or the OFSET trial.
Thank you. I'm happy to come again or to speak more if you have any other questions. Definitely, this is a great resource.
Next up on the podcast, we have one of the true legends in breast cancer medical oncology, Dr. Sandra Swain, with an academic and historical perspective on young patients with breast cancer and BR009.
Dr. Sandra Swain is Professor of Medicine and Associate Dean for Research Development at the Georgetown University School of Medicine and Medical Oncology Co-Chair of NRG Oncology, BR009.
Long before the trend of subspecialization in oncology, Dr. Swain was responsible for establishing the breast cancer medical oncology program at the Lombardi Cancer Center in 1988. She also served as the chief of cancer therapeutics branch at the National Cancer Institutes in the 1990s, as medical director of Washington Cancer Institute in the early 2000s, and has served as president of the American Society of Clinical Oncology.
As one of the true giants in oncology during our lifetime, many people think about your work at the NCI, with ASCO, and with Georgetown, but might not be aware of your longstanding connection with NRG Oncology. Could you speak a little bit about your connection to the legacy NSABP group and NRG Oncology? How have you juggled your career in the cooperative groups with the numerous leadership roles that you've had over the years?
I'm glad you asked this question because this has been one of the most exciting parts of my career. And I feel like it's one of the things that really has helped me in my career the most. I met Bernie Fisher, who was the chairman of the NSABP in 1985 when I was at the NCI as a fellow. I have a picture taken with him and several other people, and I look scared to death in this picture. What I really loved about the NSABP, led by Bernie Fisher, was the thought process and the fact that they were looking at changing paradigms. They changed the paradigm of the surgical treatment of breast cancer. These were a group of surgeons that started it, and they decreased the amount of surgery, which was considered heresy at that time, and led a huge change in treatment for breast cancer patients. So I read everything that he wrote. I listened to him all the time. I went to the NSABP meetings, which were really great, very scientific. And I just loved the way he thought because he was very methodical, very thoughtful. He thought about what was going on preclinically, took it to the patient level, and really put it in these randomized trials, which also he was one of the first to do that. As time went on, I became the PI of a couple of the trials, the NSABP B30, and that was one trial that led to my interest in premenopausal patients and ovarian suppression. And we looked at, along with Patty Gans and her group, who's fantastic, at the patients in this trial who were premenopausal and looked at amenorrhea to see if amenorrhea correlated to a better outcome. And it actually did. And that has been seen in other trials too, that it is associated with it. So the question came up, is it the chemotherapy causing a cytotoxic effect, or is it just shutting the ovaries off that is making the outcomes better? So it really led to the trial that we're going to talk about today.
I want to just put it out there to really explicitly highlight the exact question that BR009 is asking and what the primary endpoint is for this study. Are there any particular additional endpoints that you're excited about for this study?
Well, we have a lot of endpoints, but our primary endpoint is to determine whether adjuvant chemotherapy added to ovarian suppression and AI is superior to ovarian suppression and AI in improving invasive breast cancer-free survival. And it's in premenopausal women with a 21 gene recurrence score between 15 to 25 if they have negative nodes, and from 0 to 20 if they have positive nodes. And we're also looking at other endpoints for sure, like long-term toxicity. That's incredibly important. And to look at biomarkers to predict chemotherapy efficacy. Then we have symptoms and health-related quality of life questionnaires that are being done for the different treatment groups, even though chemotherapy does have known toxicities. Certainly ovarian suppression and an AI also have toxicity. So we really want to be able to compare and even look at long-term toxicities, not only for chemotherapy, but for endocrine therapies too.
You mentioned that it's a hard study to accrue to in the sense of making it appealing or clear to understand for a patient. I'm curious how you tackle that aspect. How do you explain to them this context in a succinct way and help them understand the importance of this question and, the relevance of it for their care?
Well, I think it's very hard. And the way to really tackle it is just to say out front, we don't know the right answer to this. People are giving chemotherapy, but it might not be necessary and it might cause some long-term effects. I think that's one of the issues probably with this trial is that the physicians, may have an opinion about it. And if patients don't go on a trial, they have to make a decision on how they're going to treat the patient. So they have in their mind their own algorithm. So sometimes that might affect, how they present it to a patient. The key is really knowing that there is no right answer to this. like when we first did the mastectomy versus lumpectomy trials. I mean, it's the same kind of thing. That's a huge difference in those two treatments, as this is also a big difference. I think, though, the difference for this trial is that these are young patients, and we know they have a long life ahead of them, and we want them to have the longest possible. That is one of the concerns that investigators and people have, the patients, is that they might be making the wrong choice. But I think that's true of any of these kind of randomized studies. But the TAILOR-RX and responder trials were very successful. Those trials basically did the same thing. They had chemotherapy, endocrine therapy versus endocrine therapy. It's not really different than that.
I think everybody listening would agree that the effort to move away from cytotoxic chemotherapy in young patients with breast cancer is an incredibly important goal. And as we touched on earlier in this podcast, there's certainly no shortage and a growing number of young premenopausal women who are being diagnosed with these breast cancers. And although, as you've noted, the 500 patients have gone on, which sounds like an enormous number, but breast cancer trials are often quite large, especially compared to GI cancers like I treat. These accruals actually have been a little bit less than what we've been hoping. What sort of barriers has the study team encountered for BR009? And do you have any ideas on how we might further improve accrual?
We recognize that the accrual has been slow. The centers that have done the best in accrual, who just came on actually in the spring of the last year, 25, were the Canadians, two of the groups in Canada. And two of these investigators are actually surgeons. And I think that's one thing that has really helped, because they have the long-term relationship with the patient. They not only do the surgery, they do the recommendations for adjuvant therapy. One thing I've recommended is to really get the surgeons involved with this trial so they can start talking to these young patients early on after they do the surgery, or even while they're working them up, that we have, these great trials ongoing that you could potentially be eligible for. And they also get the Oncotype DX, or the recurrence score, in these patients earlier then, because you can do it on the core. You don't have to wait for the surgical specimen. I think that's another thing that might have decreased the ability to accrue too, because the recurrence score wasn't routinely done in a lot of these patients. We haven't had problems with reimbursement there, and we can pay for it actually if there is a problem, but it hasn't been routine. So that's something that's a change. And anytime you have a change, it can make it harder. And I think it's also the patients find that it's just such a difference to get chemotherapy versus not. And a lot of them end up not wanting chemotherapy at all, knowing that they're going to get very good hormonal therapy, and if they have a high enough risk, a CDK4/6 inhibitor. So that's another thing that I think decreases our ability to accrue, knowing that we have other good agents out there.
One element that I like that you brought up was the need to engage the surgeons in these conversations. A lot of times, patients with cancer who have had a surgery arrive to their appointments with medical and radiation oncologists with a pre-existing framework in their mind of what the expected treatment will be, which is on some level good communication of a treatment plan from the jump. But at the same time, it really makes it challenging for patients to then kind of reconfigure what they'd envisioned as their treatment path by potentially doing something different on a clinical trial. How do you work to engage surgeons and the really entire treatment team to frame the setting for a clinical trial question from the start?
You can't underestimate the value of the surgeon's input, even for adjuvant therapy. And the patients develop a bond with the surgeon. What we do, we have a multidisciplinary conference, so we talk about these trials all the time. And I think that we've encouraged other people to do the same thing and make sure that the surgeons know about it, to maybe get the Oncotype or the recurrence score earlier on and be able to talk to the patient about it. Also going to some of the surgical meetings and getting them excited about this trial, because it's such an important question. That is really critical also.
Over the past year, we've been seeing increasing public uncertainty regarding the value of mainstream science and medicine. This, of course, has translated into uncertainty over the federal funding for the National Cancer Institute and cooperative groups like NRG Oncology. I personally believe that part of the problem is that we as physicians have done a poor job of communicating the value of science and clinical trials with policymakers and the general public. I know investigators out there who think they've effectively communicated through a high impact publication, a white paper, or a newsletter, but it's pretty obvious we aren't getting through to a lot of people. As someone who hasn't been shy about communicating about the importance of cancer research in the mainstream media, can you speak to listeners out there how we can do a better job of communicating the importance of science in cancer research?
I think one of the ways that we communicate and try to affect change is the work we do with ASCO and the policy team. And I did that last year in April, and I'm planning to do it again this year because I think this is an incredibly critical time. I don't think that any of the politicians would disagree about it, but they need to realize how important this is. And funding for trials like this, the OFSET study or the study we're talking about today, or some of these other large studies that I mentioned, they change clinical practice. I mean, we need to make sure they know the TAILOR-RX, the responder trial, the trial we're doing really is the future for patients and the future for their survival. I agree with you. We do need to do a better job. We do it on the Hill and talk to the policymakers, give them the talking points. I think that is extremely critical. So far, it looks like we've been successful and they haven't really cut some of the things we thought they were going to cut. I don't know what's going to happen in the future, but we do depend on the NCI budget for the NRG. One of my big concerns not only is the funding, but loss of the great minds of the early career investigators. I'm seeing a lot of people go to industry, which I'm not making a judgment. I think that, that's a fine career choice, but I really would like to see more of the early career investigators be very excited about doing clinical trials like I was 40 years ago and like I was when I met Bernie Fisher. We need to be good mentors. We need to talk all the time about how great it is to do what we do. And also to have patience. For the B30 trial, it took about 13 years from designing to reporting. For these other trials, TAILOR-RX, Responder, over 11 years. So it takes a long time. So you have to talk to people about that. It's like anything. You have a diverse portfolio. You have some long-term gains and you have some short-term gains. That's incredibly important for these early career investigators. And I've done a lot of work in ASCO raising money for early career investigators. And I'm extremely passionate about that because I think that's our future too. And we need to really, really hold on to that.
Dr. Swain, I just want to thank you again for joining us on the NRG Oncology podcast, and also truly for the decades of work that you've done to improve cancer care in the United States.
Well, thank you so much for having me. I really am. I'm excited about this trial, and I'm excited about all the investigators that are working on it. And I really appreciate your giving me time to talk about it to all of them.
Today we had Dr. Sandra Swain, the medical oncology co-chair of NRG Oncology BR009, speaking about breast cancer in premenopausal women and how we are trying to move the needle forward in this population. Next up on the podcast, to provide a real-life perspective on the impact of breast cancer in young premenopausal patients, we are joined by physician and breast cancer survivor Dr. Haane Massarotti.
Dr. Haane Massarotti has been a practicing colorectal surgeon in Florida since completing colorectal surgery fellowship at the Cleveland Clinic nearly a decade ago. For our clinical research coordinators among our listeners, Dr. Massarotti was also at one point a clinical research coordinator at the University of Hawaii Cancer Center prior to attending medical school.
For the record, I've known Dr. Massarotti for 2 decades since we started medical school together at the University of Hawaii in 2005. Dr. Massarotti grew up in Guam before attending college at Stanford University. After medical school in Hawaii, she completed residency in Pennsylvania before settling in Florida. I personally can't think of more different places, whether it's the weather, medical infrastructure, demographics, or even the political persuasions. This is probably the most interesting background of any guest we've had on the podcast so far. So, first off, honey, did I get this all right? And can you fill our audience in on this history and how you arrived at becoming a colorectal cancer surgeon?
Absolutely. Thank you, Dr. Chan and Dr. Henke, for having me on this podcast. You absolutely got it right. I have known you for, I guess, 2 decades now. I can't believe it's been that long. After I graduated from high school in Guam, I attended college at Stanford University, where I actually thought I was going to be an orthopedic surgeon. I studied health and human performance and did medical school with you in Hawaii and was influenced by surgeons, general surgeons that were very, very happy with their ability to help the people of Hawaii and with their work-life balance, and were very passionate about their work. After medical school, I did go to Lehigh Valley Health Network in Allentown, Pennsylvania, where I completed residency and met a mentor who ultimately got me down to Cleveland Clinic, Florida, where I did do a rotation in my last year of residency and immediately fell in love with colorectal surgery. I went down to Cleveland Clinic, Florida to complete my ACGME fellowship and stayed on an extra year to do an additional minimally invasive colorectal fellowship slash junior attending clinical associate year. And I haven't left Florida since. I chose colorectal surgery because of the variety it offered me, the ability to help not only cancer patients, but non-cancer patients, almost all ages, both sexes, with a variety of procedures. And I also felt that I had the ability to impact quality of lives, given that we all know someone or know someone of someone who has had colorectal cancer.
Recently, I saw one of your posts on LinkedIn, and it really surprised me when I learned that you had been diagnosed with what I recall was an invasive lobular breast cancer. Since then, you've been very public about the importance of early detection and screening. How did early detection play a role in your cancer diagnosis? And what words of wisdom or what message do you bring to our NRG oncology audience about the increasing incidence we've seen in this country of early onset cancers?
Yes, thank you so much for pivoting over to now my breast cancer experience, which to say has been quite surreal being the physician turned patient. When I was diagnosed, I was a busy practicing colorectal surgeon, starting a colorectal surgery program, very passionate and involved in the community. I was too busy and I asked my general surgery partner to just, order my screening mammogram. I waited, of course, to get my regular screening mammogram. And fortunately, it was a BI-RADS 2. But that being said, given that I had very, extremely dense breasts and cysts, my partner actually advocated for me to get a breast MRI, which, there's a lot of controversy out there on breast MRI, but he was able to advocate it, get it approved by the payer, despite not meeting any kind of high risk factors for breast cancer that are recognized by payers. I waited 6 months, of course, because I was busy. I was working hard. I was building a program. I felt well. And I ultimately got the breast MRI, which is what and ultimately ended up being a BI-RADS 4, which was biopsied and initially was LCIS with poor features. And not to go into my whole cancer story, but from there, I put the foot on the accelerator for addressing this. What started as, okay, I'm going to only have LCIS, I'll be on tamoxifen for a while, for 5 to 10 years, ultimately ended up being invasive lobular carcinoma, grade 3, pleomorphic features. Fortunately, it was early stage, it was 10 millimeters, no negative. The messages for early detection, from my perspective, as a physician or anyone, it could be, not even any professional, someone who's busy taking care of others. You do have to take care of yourself. And we say this all the time as physicians. We say this as parents. If there are other parents out there, you have to care for yourself before you care for your kids. But this is the first time I was actually ever reminded of that. In terms of early onset, the message is get the screening done. To actually do that and take the time is hard because we care about what we do. We care very deeply about what we do. We're very passionate about what we do, and that passion must be translated into self-care. And my message is early cancers are happening in younger and younger individuals. From a colorectal cancer standpoint, it takes, I think, about 6 months to get any sort of diagnosis from any symptom onset. My message is if you are one of these individuals or a family member of an individual, to advocate for early cancer screening because cancer is no longer a problem of young folks, particularly colorectal cancer, breast cancer. Those are the two I can really talk about, at least any kind of experience or academic background. Don't wait to get the colonoscopy. Don't wait to get the mammogram. There's a lot of barriers, including the way we were raised of, nope, this is not a, I don't have this. There's no way I have cancer. I'm young.
I will confess to being the busy physician that hasn't been to the dentist in the last year, let alone plugged in with my primary care physician probably in the last couple of years. For many of us at NRG Oncology, of course, being on the physician side of the equation or healthcare provider side of the equation is the only thing that we've ever really known. We've seen some of your posts on this on social media, but can you talk about how your cancer diagnosis fundamentally changed your perspective on cancer and your approach to medicine? And I'm curious to know, from our perspective, from a clinical trialist
Mhm.
angle, did your diagnosis change your awareness and appreciation for clinical trials?
I've been thinking about this and writing about it, about my approach to medicine. And I've always been an empath. I've always been compassionate. I spend time with patients, but how often did I actually see the patient and their perspective? One of the biggest things that really opened my eyes is I'm a physician and I had access to the best care for my breast cancer. I had quote unquote an insider route to getting the care that I needed. And even that was challenging. There were still delays. There were still challenges with the delivery of healthcare in the macro environment, the political, the financial perspective. And I am fortunate enough to have health insurance, to have resources. And even that was a struggle. And sort of the mental and emotional impact of that of, am I going to be here to watch my son grow up? Is this the end of my life? Or how am I going to get this done? How am I going to possibly undergo mastectomy, double mastectomy, chemotherapy? How am I going to get my treatments and still work and still provide those questions where it became very real. And so now when I take care of patients, whether it's cancer or not, I do take the extra time to really understand from a whole patient perspective what their worries are. Like, I ask them, what are you most worried about? And I don't know if I ever asked that before. Or what scares you most about this? Whether you're seeing a patient for life threatening diagnosis like cancer or quote unquote a simple appendectomy, to that patient, the appendectomy might not be so simple.
So moving on, at least for me, it never really dawned on me in medical school and even throughout much of my training and residency that I could be a clinical trialist or get involved
Mm.
with something like NRG oncology. Despite that cancer is the leading cause of mortality in the United States, it's remarkable how few medical students ultimately pursue a career in cancer research, be it basic science or clinical research. If you could go back those 20 years and speak perhaps to our fellow medical school classmates, knowing what we know about your own cancer, how few people actually end up looking at cancer research, what might you say to them?
Our medical school was fantastic, focused on primary care and helping our local community, which is very, very important. But I would probably tell them that there's so many ways you can help patients. Clinical medicine is the core of helping patients. That is why we do this, to help patients. But I do think offering them opportunities to, whether it's shadow or intern clinical researchers, this is the day in a life of. And I think that would probably have the biggest impact in terms of showing them this is what your life, in addition to taking care, hands on, taking care of patients. I think that would probably be the best way. As a surgeon, I learned by doing. I want to be knee deep in it. So I think having those opportunities, and we're not, it doesn't have to be something drawn out like a whole month, but, even a day here and there to really kind of show them there's not one path to taking care of patients. And I think we can't see that when we're so excited about medicine and the opportunities we know we want to take care of patients are important. But in terms of this is how it can actually help patients. And there's so many ways, whether it be with NCI or with any other sort of academic setting, or being a principal investigator in a small community hospital, or working for any, whether it's government, non-government organization that has a positive impact. So just giving them that opportunity to hang out with someone, to show them this is what we do, this is what our life is like, and this is also an option. You don't have, there's not one path in taking care of patients. So
I think that's huge, honestly. So I went to medical school at WashU in St. Louis, and there is a big emphasis there on research, and a lot of students get involved in medical research. But I actually think, as somebody who did, medical research projects between years of med school and the summers and things like that, that it almost would have been more impactful for me, at least from a clinical trials perspective, to, like you said, spend a day in the life and be a fly on the wall in the corner of a cooperative group meeting. And there may be some limitations on like protections of data or whatever that might limit that in some way. But getting to see what is possible through the eyes of somebody who is in that role, I think can be hugely impactful, more than getting assigned a retrospective chart review.
Mhm.
A lot of us here at Energy Oncology, and shifting a little bit, do a lot of also uncompensated volunteer and after hours work to bring these new clinical trials to patients. One really interesting topic you've posted about on socials is on physician wellness. What kind of national trends have we been seeing, do you think, in terms of life expectancy for our female physician workforce in particular? And how has your diagnosis impacted your perspective on the proverbial work-life balance?
something I've always been passionate about is mentoring female surgeons. And when I was a clinical associate professor who worked with residents and medical students, and as a female physician mom in a very busy practice, I think there are different challenges that female physicians, particularly surgeons, face in taking care of patients and taking care of themselves. But the data out there is that severe preeclampsia and associated complications are, pregnancy complications are much higher in female surgeons compared to their non-surgeon counterparts. And that was in a study in JAMA in 2021. The other interesting study is that women usually live longer than men. We know that, in the United States, women have longer life expectancies than men. But female physicians, we lose that advantage despite having questionable comparable incomes, similar education. You work and then you go home and you take care of the kids. And I'm not saying this is that all females do this. There are great male physicians that I personally know that take great care of their kids, but this is sort of a general perspective. And then the demanding schedules during training, I think, does have an impact on our fertility and our ability to have children. And the data is there, but I think the more important question is, what can we do about it going forward? I've completely revolutionized the way I practice medicine. So I do work from home utilization management. So that's been great. I get to be with my son. I get to still help patients from a much more global perspective and to stay clinically active. I do locums very regularly. I go to small critical access hospitals. I'm no longer in a big tertiary referral centers, and I learned so much from that experience. But given that I was diagnosed with cancer, I really saw, when I pass away, I'm not going to be remembered for that fantastic dissection on my robotic APR and my negative margins and my TME specimen. I'm not going to be remembered for that. Yes, I very proud of that. Don't get me wrong, but I want to be remembered for how I functioned in the society as a mom, which ultimately is really what matters. So I did gain that perspective and change my lifestyle because of that. I've committed to really changing my lifestyle, which is very hard as a busy physician. I'm talking my diet to minimizing plastics and overhauling my kitchen actually on what products I actually ingest. I've committed to an active lifestyle and I do exercise 45 minutes a day, 6 days a week. And trust me, I have so much respect for my mentors and the path that brought me here. And I will never, ever change that. But this is the path that I practice now, and I fully own it and I fully embrace it. And in 10 years, I might decide, okay, I'm ready to get back into this. When my son leaves, maybe I will want to be an employed surgeon. Life is short and you never know what's going to happen, but this is what was working for me now. And I'm very, very happy with my work life balance. And I would I hate to say this, I'm not saying cancer is the best thing that's happened to me, and I'm not, but it really has made me a better physician.
You know, it's funny that you say that cancer was the best thing that has ever happened to you. You may recall 20 years ago, President George W. Bush's press secretary, Tony Snow, when he was diagnosed with metastatic colorectal cancer, also said the same thing, that cancer was the best thing that ever happened to him. So I just want to say again, I really appreciate you coming on the podcast today. For those of you tuning in and listening, today we had Dr. Haane Massarotti join us on the NRG Oncology podcast on her career as a colorectal surgeon and her perspectives as a breast cancer survivor. Haane, thank you for joining us today.
Thank you so much for having me, Dr. Chen and Dr. Henke. I really appreciate this opportunity. I'm in awe of what you do and thankful for spearheading the Energy Oncology podcast. And you have a lot to be proud of, and your passion is not unnoticed. And I'm truly honored to be asked to be on this podcast. And I look forward to further collaborating.
For those of you who haven't already subscribed, you can follow or subscribe to the podcast on Apple, Spotify, or YouTube. You can also follow Lauren and I on Twitter, or X as they now call it, where we post updates on NRG Oncology initiatives fairly frequently. Lauren's handle is at Lauren_Henke, and my handle is at Stephen Chun MD. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks everyone for tuning in, and happy clinical trials.